Here is your question. Right, so if you have read and understood considering a critical care scenario, kindly tell me, how would you manage this patient?
Yes, ma'am. I would manage this patient according to the ATLS protocol, following the ABCDE approach. I'll initially go for airway. I'll look for signs of airway burns or inhalation injury. Since this patient has soot in the nostril, I am suspecting that there is airway injury, burns or inhalation injury. So I have to consider intubation for this patient now, because there might be airway edema, which might be difficult to manage later on.
How
Then
would
for
you
the
take
breathing,
care
I
of
will.
that? Just suppose there is edema, airway edema. So how would you take care of that?
If there's airway edema, I will go for nasotracheal intubation, or if that intubation is not possible, then I have to go for cricothyroidotomy or tracheostomy now.
Good. Would you be able to, considering the stem, would you be able to calculate the surface area of burn for this particular patient?
Yes, ma'am. I will use the Wallace rule of 9 to calculate. On face, it says face of 4.5 trunk. If it's whole trunk, then it's anterior trunk is 18, left arm 9, both thighs is 9 and 9, 18, 36, 9, 45. It's around 50, ma'am. Yes, 49, 50.
Little bit more. Okay, good. Considering that, how would you? Yes. Right. Okay. Can you? Would you be able to tell me how would you take care of the fluid maintenance or fluid requirement of this patient?
Yeah, for this patient, I will use the Parkland formula, whereby the fluid requirement is calculated by it is given as 2 ml into total body surface area burn into body weight in kgs. So here patient will, if it is
70 kg
average,
yes,
70 kg, then he will be getting around 35 into 2, it's around 7 liters.
Yes. Okay.
So here I will divide it into two parts.
Yes.
The first half I will give into the first 8 hours, then the rest 50% in the next 16 hours.
Very good. Okay. Can you please tell me, if you fail to manage this burn patient, what are the complications that you should be alert about?
Yeah, so complications should be patient will develop dehydration, which will also lead to hypovolemia, shock, and it will also lead to AKI. And also patient can develop infection sepsis and also coagulopathy, DIC, and patient can develop stress ulcer and also electrolyte imbalance like hyponatremia, hyperkalemia, hypocalcemia, and also if there is a
considering the burns that patient has acquired, would you be able to tell if they are superficial or deep?
This is a second degree burn, so it is deep partial thickness, ma'am.
Yes. So how the depth and extent of a burn is evaluated or assessed?
The extent is by the surface area, involvement of surface area, and the depth is by the involvement of the layers of the thickness. Yes. So if it is superficial, we have superficial involving epidermis. We have the partial thickness, that's the epidermis and papillary dermis.
Very good. One of the complication of burn is ARDS, acute respiratory distress syndrome? Can you define the term, please?
Yes, ARDS, it is an acute respiratory failure, which is non-cardiogenic pulmonary edema, whereby there is which will lead to hypoxemia, and acute and decrease in lung compliance, which will not respond to oxygen therapy. Ma'am.
Is it possible for you to define or tell me the causes of ARDS other than burn?
Yeah. So yeah, it could be other than the inhalational injury. It could be aspiration pneumonitis, pneumonia. It could be shock. It could be burns. In massive blood transfusion, DIC, in conditions like acute pancreatitis.
So basically, you are dividing into direct causes and indirect causes, like systemic, and the direct ones are
Yes,
related to the lung. Okay, good.
lung, yes.
Can you please tell me if patient develops or goes into ARDS, where would you manage the patient?
I'll manage this patient in the ITU, ma'am.
Yes, okay. And who would you involve in the management?
I will involve the ITU registrar. I'll involve the anesthetist. I'll also involve the chest physiotherapist. I'll involve the dietitian for the nutrition, and also involve the plastic surgeon on the later stage.
Very good. Why would you involve the plastic surgeon?
Yes, if since there's a second degree burn, there might be scarring, and the patient might need intervention, where the patient might need grafting and all.
Yes, considering that patient has acquired burn on the trunk, what is the complication that you should watch out for?
For the burn, ma'am?
Yes, on the trunk. Burn on the trunk.
Yes, on the trunk, yeah.
Yes, please.
If this is I need to check whether he has a circumferential burn on this trunk, especially the chest.
Yes.
Yeah, so because if there's a circumferential burn, then there might be respiratory compromise, where his chest movement and breathing will be reduced. Therefore, I need to go for urgent fasciotomy.
Very good. This is what I wanted to hear. Okay, can you please tell me, considering ARDS, what is the pathophysiology behind it? How does it develop?
Yeah, we have 2 stages. In the acute stage, there is acute inflammatory reaction, whereby there's increase, there's damage to the pulmonary capillaries, thereby making it more leaky, whereby the inflammatory exudates consisting of cytokines and cells like neutrophils, they leak into the interstitial spaces, inciting an inflammatory response, thereby causing also damage to the alveolar basement membrane. And in the second stage, in the reparative stage, there's deposition of fibroblasts and proliferation of fibroblasts, where they will attempt repair. If repair fails, then it will lead to pulmonary fibrosis, leading to lung scarring.
Good. Can you please, would you be able to read X-ray, please? This imaging for me.
This is a X-ray of the chest posterior anterior view, showing lung infiltrates on bilateral lung field, which is typical of acute respiratory distress syndrome.
Very good.
There's also obliteration of the claustrophrenic and cardiophrenic angle, and also there's enlarged heart shadow. Probably this is a cardiomegaly. And the other findings, the trachea is central in position, the bones are normal.
Right. Can you, yes, good. You told me about, all right, okay. Considering the patient had burn on the face, other than face, what is the criteria to admit the patient or manage the patient in the burn unit?
We have to consider the total surface area burn. In case of adult, it is more than 15%. In case of child, it's more than 10%.
And elderly? So I'm just interested in knowing the criteria for admission into the burn unit. One is
First
face.
thing is the surface area. face involvement of
face
facial
and
burn.
the genitalia, and then there is
Genitalia.
if you tell me the surface areas, then how much should be the surface area for a child, for elderly, and for women in order to be admitted to the burn
In
unit?
adult, more than 15, child more than 10,
Yes, right, right.
and
Elderly.
elderly more than 5. Not sure of that.
Yes. And then it also depends if the patient has is a chronic multi
Like comorbidities.
comorbidities. Thank you so much. Yes, thank you so much. Yes. Just started your timer and here is your question. Right, so if you have read and understood, considering this communication station, kindly begin.
Hello, I'm Fozia, one of the surgical doctors here. May I confirm your name and relation to Mr. X?
Good.
Yeah. Are you Mr. Man? Are you
Um,
Mr. Man? I'm Alice. Are you Mr. Man? Who is
no,
Mr. Man?
I'm Fozia, covering for Mr. Man today. He has been called away to attend an emergency, and I'm sorry,
But he
could not
promised that
attend.
he promised to see us today.
Yeah, he was supposed to attend to see you today, and unfortunately, an emergency came up, and he had to address that. And I'm here to take care of you and clear and talk to you about Mr. X.
This is not done, doctor. Mr. Man had promised us to see us today, see my husband today.
I'm really sorry, but in case of emergencies, the clinician has to always prioritize. And I'll make sure when he comes back, and I'll arrange a meeting of him with you.
Now, what about my husband, doctor? He was advised for CT scan, and we are here. When are we going to get it done now, doctor?
Unfortunately, it's a bad news. We were planning to do a CT today, but our CT machine is not working. And we have called our engineering guys and they are looking into it. But
What?
it
CT
seems,
scan is not working? How come, doctor?
I'm afraid there is
How
some
many bad
technical
news
error.
are you going to tell me? First thing, Mr. Man is not here. Second thing, the CT scan is not functional. So what I'm going to do with my husband now, doctor?
I'm sorry, we're here to take care of your husband, and we're here to provide him the best possible care. And we will do our best to ensure that your husband's care is optimal.
Okay, when will the CT scan be in place? Tomorrow?
No, I'm afraid they are saying it would take this week, and it will be available.
Oh my God! Next week. No, doctor. My husband is already suffering. You know, he's having this tummy swelling, and then he's having difficult time. And then now, you people have advised for CT scan, and now you are saying that CT scan not functional, and like he's suffering, doctor.
I'm sorry, but we're doing all possible things to make him comfortable. And regarding his tummy fluid, Could it please ask you how far you know about your husband, Mr. X?
I don't know
Sex
much.
condition.
I think
His
Condition.
I
health
think
Good. Yes.
they took out some fluid from his tummy, and then I don't know what was the result. They didn't tell me yet.
Oh, okay.
Can you tell me, doctor, what was the
Yeah,
result?
yes, I'm glad to help you. Your husband, Mr. X, came here with short of breath. He was quite breathless, and he was having tummy fluid. And we drained some fluid, and we have sent it for analysis. Some of the tests have came, and some are awaited. And unfortunately, one of the tests is showing some nasty cells, cancer cells
What?
in the fluid.
Cancer cells. Oh my God. Oh my God. Cancer cells. So he has cancer.
Yeah, yes, it's a possibility. The cells are there, so he might be having cancer.
Oh my God. Oh my God.
I'm sorry, I'm the one giving you a lot of bad news.
Is it really serious? I mean, what cancer he's having, doctor?
We basically needed the CT to see where is the cancer coming from and how much it has spread, so that we could plan further. And as for now, we just know that there are cells present in the fluid and they are cancer cells, and we are not sure from where it's arising and how much it has spread. That's why we needed to do a CT.
Doctor, you're saying that he has cancer cells and then he needs CT to know about this cancer cells in detail, and your CT is not functional in the hospital. Then why don't you refer him to another hospital, doctor, if it's not available here at present?
If we think that it would take much longer time than expected, then we will definitely refer your Mr. X to for another hospital for the same. But it would take some time. It will be at the CT machine as expected. Will be good to go next week, and I'll make sure that I'll reschedule your Mr. X's CT the next
Can't
week
this
earliest
hospital
possible.
prioritize, since my husband is having cancer, can't this hospital prioritize him and then send him just for a CT scan to another hospital? Just send him in an ambulance, get a CT done, and get him back.
I'll talk to my consultant, Mr. Mann, and see what we can do about it regarding the referral for the CT scan. But I need to talk to my consultant about it.
So what, will he need operation, doctor?
As far as the presence of cells in the fluid is, it suggests that the cancer is advanced. And for further treatment, we will need discussion in the multiple disciplinary team where different specialists are present. And sometimes in these as these conditions, the surgery is not option, and some other options like radiotherapy, chemotherapy, and other options are tried.
How long does it have, doctor?
I'm sorry, it's a very difficult question. I don't have an answer for that. Because but I promise you, as we move forward, communication, we will have more meetings with the oncologists, and the communication will continue forwards, and we will get more knowledge about it. But I'm sorry, I don't have a clear answer.
Surely you don't have anything good for me, doctor, today, or for my husband. First thing, Mr. Man is not here. Second thing, city is not functional. Now he has cancer, which you are saying it's aggressive.
I'm sorry.
I'm left helpless, doctor. What are you going to do now?
We will collect the test which we have sent, and meanwhile we will try to keep Mr. X as comfortable as possible.
And
We will address his issues.
he's having difficulty in breathing, doctor.
Yeah,
Should
I'll
he be
address
like that, until the CT scan is in place? He should be like breathless, kept like that, unattended.
No, we will attend that. I'll drain some fluid. It's because of the fluid in his tummy, which is pushing his lungs up, and it's making his breathing difficult. And I'll arrange for draining some fluid from the
Yeah,
tummy,
do that, doctor.
or
Get
maybe
it
I'll
done,
start
please.
some medicines to decrease the fluid. Would that be fine?
Summarize and end.
I'm sorry, Alice, I was the one giving you bad news today. Your husband, Mr. X, was referred by GP here with a shortness of breath and fluid in the tummy. We have run some tests. We need a CT to be done. And unfortunately, our machine is broken and it would not be done. And it would be after 1 week that we will be able to a CT. Meanwhile, we will drain some fluid from the tummy to make him comfortable. We will increase his painkillers or start the drugs or some drugs to decrease the fluid. Would that be fine?
Good. Yes.
No, doctor. I'm not happy.
I'm sorry. Is there anything else I could help you, or anything that I can do for you or Mr. X?
Yeah, get him an appointment, CT appointment in another hospital. Get it expedited, and then start his treatment, whatever as soon as possible.
I'll talk to Mr. Mann then.
I can't see him suffer anymore, doctor.
I'm sorry. I understand that you are very concerned and caring for your husband. But once Mr. Mann comes,
of course I am.
Talk to him.
Of course I am. He's my husband, after all.
Yeah, I can understand it. And once Mr. Mann comes over, I'll make sure that I'll talk to him about these issues and try to arrange your CT. Talk to him about arranging your CT at some other referral center or other hospital.
Good. Thank you, both of
Yeah.
you. Very good. Very nice. Yes, Dr. Karma. Can you give the feedback?
Thank you, Dr. Foss.
Thank you.
She was very calm.
Yes.
I tried to poke her, but
Yes.
she didn't back down. She was very calm, and then she tried to address all my questions.
Yes.
Issues, yes. And
Very nice.
I think she managed well. I thought she will get
Slip back, but she
when
didn't.
I poke her. Yeah,
back.
I thought she will lose herself, but she didn't lose. She stood strong. So
Very
nice,
good.
Dr. Foss.
She's getting better day by day. I can see she can do it, and she can bring the voice as well.
Yeah.
She wants to.
Maybe a bit of bit of confidence in the voice, like
yes,
because the being like calm and like being confident, these are two different things. So maybe
calm
a
is
bit
good,
of
but
confidence,
yes, she'll get there definitely.
because we have to
Good.
convince the patient.
Yes, thank you.
Thank you.
Okay, here is your question. Right. So if you have read and understood, considering its surgical and administration, kindly tell me what are you looking at in picture A and B?
Picture is the medial aspect of the foot, and picture B is the lateral aspect of the.
Good. Can you please tell me all the bones which form the foot?
So there are tarsal bones and metatarsal bones and phalanges.
Yes,
The
how
tar-
many? Five
Um,
each? Yes.
Yeah, so the tarsal bones are calcaneum, talus, sorry,
Navicular. Yes, yes,
navicular,
yes.
and then cuboid, 3 cuneiforms, medial, intermediate, and lateral.
Yes.
And then we have 5 metatarsals, and then 3 phalanges for the second to fifth toes, and for the great toe we have 2 phalanges.
Okay, good. Can you please identify number 9 in picture A, please?
Number 9 is the lateral tubercle of the talus.
Talus, very good. Okay, if you can identify 11, please.
It is the medial malleolar surface of the talus.
Very good. Okay. Can you, would you be able to tell the relation of medial malleolus
Medial malleolus
or the
relation,
structures, yes, pass through it?
which pass behind the medial malleolus.
Yes.
So there are tendons and vessels which go to which are from the posterior aspect of the leg. There is tibialis posterior. Then we have flexia hallucis. Then we have the posterior tibial vessels and the posterior tibial nerve. And then we have the flexor hallucis longus.
Okay. Can you please identify 21?
21. It is the tubercle of the navicular bone.
Very good.
Tuberosity of the navicular.
Tuberosity of the navicular bone. Yes. Good.
Yeah.
Can you identify 12 over here?
It is the tubercle of the calcaneum, medial
No,
tubercle.
medial process.
Tubercle. Okay, medial
Right.
process.
Right. Coming on to picture B. What is
Yes.
19?
It is the sulcus. I
Tarsal
can't.
sinus.
Sorry. Yes. Sorry.
What
sinus.
is the significance of this sinus?
It there is a tendon which passes through it.
And
And
entrapment of tendon can lead to?
I can't. I don't know. Sorry.
Okay. Can you please identify 2 over here?
It's the cuboid bone.
Okay. 8
It is the lateral
process. Yes.
process
of
of the
calcaneum.
calcaneum.
Can you please tell me how many arches there are in the foot?
So there are 3 arches: medial
Yes.
longitudinal arch, lateral longitudinal plantar arch. Sorry. And then there is the transverse arch. The
Can
medial
you,
arch
yes, please
is
tell me
formed-
the components of each arch.
Yeah.
Yes.
the medial arch is formed by bones which consist of the calcaneum, the talus and navicular, and the 3 cuboid bones, and the 3 medial metatarsal bones. It also contains some ligaments,
Yes.
which are the deltoid ligament, spring ligament, the interosseous ligament, and the long plantar
And the muscles?
ligament, and the short ligament. The muscles are tibialis anterior posterior, and this one more, sorry.
Flexor hallucis longus, this one. Longus and brevis. Okay, good. Right. Can you, yes, please. Tell
The
me.
lateral arch is formed by the calcaneum, the cuboid bone, and the lateral two, sorry,
All
metatarsal.
right. Okay, good. Thank you. Can you look at the diagram C, D, and E and identify the circled
So
structures, please?
yeah, 6 is the deltoid ligament, 18 is the spring ligament.
How
And
deltoid ligament is formed?
it has 4 parts.
Yes.
It is formed by the anterior talotibial, posterior talotibial, and then calcaneotibial and the navicular tibial ligaments.
Can you tell me the attachment of the deltoid ligament, please?
So it is attached to the navicular bone, Anteriorly, it is attached to the
Tuberosity of the navicular, okay. And then
tuberosity of the navicular bone. It is attached to the neck and
talus,
body
yes.
of the talus. Then it is attached to the calcaneum, the medial surface, and also it is joined with the spring ligament.
All right, good. Okay, can you identify number 1 and 3 in picture D quickly so that we can move to the next one?
So 3 is the calcaneofibular ligament, and 1 is the anterior
Hello,
tibio.
very good. In picture 3 and 19 in E.
19 is the transverse talo
No.
transverse. 19
Posterior, yes. Hello.
posterior is 20, isn't it? Posterior tibiofibular is 20.
Yes.
19 is
Posterior is tibular, this is talofibular.
Yeah.
Okay, and 3. Okay, can you also tell me these? Or I have missed one. Okay. All right. Can you please tell me what you understand by the metatarsal joint of Chopard?
so metatarsal joint is formed by the talonavicular joint and the calcaneocuboid joints. The talonavicular joint is the synovial ball and socket joint, and the
Yes.
calcaneocuboid is the synovial plane joint.
What are the type of movements which take place on this joint, subtalar joint?
It is eversion and inversion of the foot.
What
take
are the
place.
muscles which cause these movements?
So medially we have tibialis anterior and posterior, along with the hallucis longus muscles, and lateral and on the lateral side we have peroneus longus.
Can you please
peroneus.
tell me this ankle joint is most stable in which position and why?
So the talus is broad anteriorly and is narrow posteriorly. And the anterior tibiofibular and posterior tibiofemoral form a socket-like joint in which this talus fits in. So when the anterior part of the talus fits into this socket, it is more stable because the widened portion is inside the joint, which provides stability. Meaning that if we have dorsiflex the foot. In plantar flexion, the posterior part of the talus is in the socket, and it is narrow and less stable than in the.
So first and simple answer is in dorsiflexion, and then if examiner asks you why, then you explain all this. Okay.
Okay.
Yes. Good. One last question, maybe we can ask if you can identify what you're looking at. What kind of image is this?
The tendons.
Yes.
Foot. Yes.
A foot, dorsum of the foot. Maybe
Yes.
you can identify number 7.
Extensor hallucis longus.
Okay. And 6, please. 6 is here. Going to grade 2, and then it's starting from here. Which muscle could it be?
Sorry, I can't identify. Sorry, I've not done the muscle.
Can you tell the 12?
12 is it the? I can't. Sorry.
Okay, these like this is like your homework for tomorrow.
Yes.
You
I've not done
can-
the muscles in blood
Yeah.
vessels.
Good, thank you. So this will do tomorrow. Good one. Where is your question? Right. So if you have read and understood, considering it clinical examination station, can you begin?
Yes. I will enter the room. I will wash my hands, introduce myself.
Yes.
Hello, I am Dr. Fariha Mariam, one of the exam candidates. I will explain the procedure. Today I have been asked to examine your leg, which includes looking and feeling and moving close at them. I'll gain consent. Will that be okay with you?
Yes.
Okay.
Continue.
Then I will expose. I will ask, can you take off your gown and keep your shorts on
Very good.
for the purposes, and then afterwards I will position the patient in a standing position.
Good.
Then I will start with an inspection. I will get down on his leg level and I will start examining the patient for the varicosities along the course of long saphenous vein and short saphenous vein. And if there are any perforators, any scar marks, any edema, any signs of venous insufficiency like lipodermatosclerosis or venous ulcers or venous eczema.
Good.
And then afterwards, I'll ask the patient to cough to see the incompetence of the vena varix, competence on the vena varix.
Very good. Yes.
Afterwards, I will move on with a palpation. I will ask the patient, now I'm going to feel around your leg. Do you feel pain anywhere? And then I'll start feeling the temperature from the dorsum of my hand, distal to proximal. And then afterwards, I will check for the tenderness while along the long and short saphenous vein and varicosities while looking at patient's case.
Yes.
And afterwards, I will check for the blowouts by a Figan test. If there are nodularities at the point of expansion, then I will try to compress it and see if there is an incompensability of the vein.
Good.
And and at the point of maximum expansion, I will try to do the short set in which I will keep my hand on the proximal part of the vein and tap at the distal end and see if there is a transmission of the staph and the proximal side. It shows the incompetence of the vein. And also I will check for the limb edema.
Good. Then.
Okay, and I move on up more proximal to the vena varix, which is 4 centimeters below and maybe a little to pubic tubercle. In there where I will check I will ask the patient please cough for me and see if there is any compensation or bulging. And then I will place my fingers to see the cuff impulse and check the cuff impulse pulsability or compressibility, and my palm to see the to feel the thrill. Afterwards, I will ask the patient to lie down and have his leg put, and while doing that, I'll explain the patient. I'll bring his leg to 45 degrees. I will do the reverse Trendelenburg and make the veins proximally and put the tourniquet at the sphenohumeral junction, and I'll ask the patient to stand up. And to see if there is refilling, and then I open the tourniquet and see if there is a refilling from below or upward, or if there is so, then if it is controlled, then it could be sphenohumeral junction incompensability.
Good.
And then I will do the modified MRCS test, in which I ask them for multiple tourniquets if they can provide. If they cannot, then I will do.
There will be only one tourniquet. How would you do it?
Okay.
Yes.
But then I will do one by one at the different level. Like
Very
I'll
good.
ask the patient to lie down, milk the veins, and then put the tourniquet and ask
Good.
him to stand up again below and above the knee.
Yes.
And then again, I'll do that, and I will do in both. I will try to do it in both the legs. First in the affected and second in the normal leg.
First, in
And
the normal, the examiner will say consider. Don't do it. So then you'll do it in the affected one. Okay. Now
Okay.
begin. Continue. Yes.
Okay, afterwards, I will do the modified purchase and tourniquet. The test will be
Yes,
done
that is
side
done.
by side.
Again, yes.
And then I will do the,
Handheld.
I will check the pulses, and I'll
Okay,
do
pulses,
the
yes.
handheld Doppler as well at the saphenofemoral junction, and I squeeze the calf muscles to swoosh sound. If the swoosh sound is prolonged, that means there is a regurgitation of blood, so it's more likely.
Good. Good. Can you
more
please tell
likely
me
incomplete.
the finding of your examination now? Thank you.
Okay. To complete my examination,
Very
I will do the arterial exam of the lower limb and abdomen.
Very good. Yes.
Okay, and today I have examined 55-year-old male with came with varicose veins.
Yes.
I keep his shorts for the dignity purposes. On inspection, I have found that there are multiple varicosities, and there are varicosities and those above and below knee at superior femoral junction.
Yes.
and,
Modified Perthes test was negative.
Okay. Modified MRCS test was negative. Fraudulent test for and on palpation, there was no tenderness, no temperature changes.
Yes.
The Schwartz test was positive,
Yes.
and there was no thrill in thrill cup
Very
impulse.
So what are your differential diagnosis for this patient?
My differential diagnosis of this patient were the primary varicose veins.
Very good. Then,
And
other than this,
then
what could it be?
either primary varicose veins and
Yes. Incontinent femoral junction.
yes, incontinent perforators, multiple
Yes.
incontinent
Yes.
perforators.
So, yes, we discussed this yesterday as well. So, can you please tell me what investigations, what further investigations would you ask for?
I will ask for the venous duplex to
Yes.
see the competency of deep venous system, and as well as valvular level of the incompetency.
Very good. Very good. Excellent. Right. It was 100,000 times better. Very nice. One little thing, when you were telling me in observation inspection, so you told me all the new things, but you forgot to tell me all the basic things that you look, like scars and other deformities, like on visual inspection that you'll see any signs of chronic insufficiency, venous insufficiency, if there is any venous edema, atrophy, any ulcer, these things you forgot to mention. Otherwise, it was good. And when you were presenting, don't say, because you've already done what you've done, but then don't say that how you ask the patient to expose him or herself. You don't need to say that. You just tell the findings, right? And you said you started off very nicely that if time would have allowed you, you would have completed with all the things that you wanted to do. And then you started off that you examined today 55 years old who presented with, and then what was your finding? So very nice, excellent. Good.
Okay.
Good. And here is your question. Right. So if you have read and understood, considering a surgical pathology station, kindly tell me what are your differential diagnosis?
Yes, ma'am. Ma'am, my differential diagnosis would be squamous cell carcinoma, basal cell carcinoma, malignant
Yes.
melanoma.
Very good. Okay. Can you please tell me how would you confirm your diagnosis?
So I would be doing an excisional biopsy
Yes.
with Mohs microscopic surgery and frozen section. If the lymph node is positive, then I would also go for FNAC of the lymph node
Okay.
or
What
sentinel
are
lymph node
the
biopsy.
causes which contribute to this condition?
Uh, it can be prolonged irritation, prolonged exposure to the sun,
Yes.
immunosuppression,
Yes.
and exposure to ultraviolet rays.
Yes.
Also, certain genetic and hereditary factors,
Very
familial
good.
predisposition, and age.
Very good. Okay. Right. After you have diagnosed, confirmed and diagnosed, what are the treatment options that you can offer to the patient?
After diagnosis is confirmed, then I would like to go for chemotherapy or radiotherapy after
Okay.
surgery.
Yes. What are the parameters or what are the factors that you'll consider once you'll suggest once you'll suggest the treatment for the patient?
So I would look for the ulceration, Breslow thickness, Clark's.
Not for this one. Okay, until unless you're ruling it out with malignant analysis. Okay, continue please.
Breslow thickness, then Clark's classification,
Yes.
superficial ulceration,
Yes.
peripheral margins and the deep margins, lymph node
Yes.
positivity, and
Yes.
also satellite lesions,
Yes.
and other indices of mitotic indices of suggestive of malignancy, such as increased mitotic rate, loss of cell polarity, increased nucleocytoplasmic ratio, pleomorphism, and
Very good. Okay, what are the risk factors which are contributed with which you can advise to the patient to avoid after patient has had diagnosis once? Or what are the measures patient can take in order to avoid exposure or condition?
Yes, so a patient has to be very watchful if to avoid sun exposure. If
Yes.
there is any change in the color, borders, increase in the diameter, or any
Yes.
new lesion in the vicinity or anywhere else in the body, a patient has to report to the hospital
And
in view of high suspicious.
avoid sun exposure. Use
Use sunscreens,
Yes.
which would, yes, ma'am.
considering that it's hypercoagulable condition as squamous cell carcinoma or any skin carcinoma. So can you tell me what are the risk factors, what are the conditions that, or complications that you should watch out for?
So I would watch out for any coagulation disorder, such as
Yes.
deep vein thrombosis or thrombophlebitis, also
Yes.
hematoma and seroma formation.
Yes. Considering it's yes. So how would you suggest, since it can lead to serious consequences of thrombo? Yes.
Yes, ma'am. Considering
you-
this
yes.
as a
Like
as a hypo,
yes, what I wanted you to tell me that what are the features and how would you take care of them? Would you ask the patient to take anticoagulants of any particular type, or how would you take care of the hypercoagulable state? So you'll maybe ask for the lifestyle modifications, maybe smoking, maybe what more can you tell me? With people sleeping in my
yes,
getting
patient.
yes. So, all right, you'll ask for, okay, if you have to give an anticoagulant to a patient who already has a squamous cell carcinoma, what would you advise? Which anticoagulant?
So, ma'am, I would like to give him on warfarin, which is a long-acting anticoagulant, vitamin K inhibitor, and I would
Okay.
like to maintain his INR between 2 to 3. So, at the same time, taking precautions to monitor his INR routinely. And if patient has to undergo any surgery or any procedure, then I would shift patient to heparin after stopping warfarin 5 days before surgery. Depending
Okay.
on the procedure, whether it's minor risk procedure or a moderate and severe risk procedure, I will start heparin again superimposed with warfarin
If you
after the surgery.
if you fail to manage squamous cell carcinoma, what are the complications you should expect for?
There would be distal metastasis
Yes.
and a regional lymph node metastasis. So it would lead to regional and distant complications.
Yes.
Distal metastasis would be in the bones, lung, and the brain. And
Yes.
it will produce various symptoms depending on the system to which it has metastasized.
All right. Okay. How should that be taken care of?
So
Once.
first,
Yes.
to check for the distal metastasis, I would do routine evaluation with CT thorax, abdomen, pelvis, and also brain. Then, if the metastasis is found in the bone, radiotherapy should be given to the patient with or without chemotherapy.
Yes.
Also, I would like to go for certain palliative measures depending on the localization of the metastatic tumor.
Yes. Okay. If there is a reappearance of the carcinoma, what are the measures you'll take?
So, if there is a reappearance, then I would, sorry, ma'am, I would, I don't really
You'll
understand.
re-excise the tumor, but then how would you consider, like, what margins would you keep in your mind? Or
Yes, ma'am, superficial, peripheral, and the deep margins, and also lymph node status is very important. Uh, Along with reoccurrence with the distal of the distal metastasis.
can you please, if you can describe this lesion for me, you're looking at patients.
Yes, ma'am. Ma'am, it's erythematous nodular lesion with central crusty incrustation and dry crusty appearance on the
Yes.
left side of the nose,
Yes.
around from the size
Yes, size. How big is
size
it?
appear around 1 centimeter, and the margins are regular with telangiectasia.
Yes. Can you
Center
tell why the surrounding of the skin is red?
it's due to dilatation of the subepidermal vessels,
Yes.
telangiectasia.
Yes. Good. Can you tell me what is the mode of spread of squamous cell carcinoma?
It spreads by the lymphatic route, either by permeation or embolization, and also lymphangiogenesis due to VEGF production of the tumor cells. Also, it spreads by local invasion
Yes.
and the metastasis.
Right. Good. Okay. So you are ready, and here is your question. Right. So if you have read and understood, considering it communication skills station, kindly begin.
Hello, I am Dr. Mamuna, the surgical doctor here. Are you Tom's mom?
Yes, yes, doctor.
Nice to see you, ma'am. I really apologize about your son condition. Please have a seat.
Okay, doctor, thank you. Please tell me what has happened. I'm so worried about my child. I don't understand anything.
I am really sorry to find you in this situation. I totally understand your apprehension at the moment. Can you please tell me how far do you know about your child's condition?
I just know, doctor, that my child fell from a swing in the school and then he was brought over here and he's taken to the surgery. But I don't understand why is it done and I don't want to go ahead with surgery. I have not
Well,
even seen.
yes, well, I am here to discuss regarding the same. If you allow me, let me tell you what happened to your child. So, his father brought the child to the emergency. When he came to the emergency, he was not doing well. So, we performed some investigations of the child, and we started resuscitation of the child as well. In the ultrasound, it showed some bleeding in his tummy. So we took the child to the operation theater straight away because it is a slightly dangerous condition for the child. I'm so
Oh,
sorry
doctor,
to inform you. Yes.
I don't understand. Like, what is the result of the patient scan? I just don't know.
Yes, I'm so sorry. I can totally imagine your condition. Well, in the scan, it shows that there is a bleeding in his tummy. There is an organ called a spleen, which actively bleeding at the moment. So, to stop bleeding immediately to save the life of your child.
Oh, doctor, but what is its importance? The spleen you call this organ?
Yes, it's a really good question. The spleen is basically an organ which is located on the left side of the tummy. It is basically involved in the immunity and defense mechanism of the body. Yes.
Okay, but is this condition serious?
Well, as in this case, when there is of the active bleeding or there is of the trauma of the spleen, it causes a large amount of the bleeding, which is very dangerous for the life. But we are here to help you, and your child is in a good hand. Our most senior and very experienced doctors are performing surgery on him. However, his condition remains serious to some extent that it may affect his life.
Oh, doctor, I'm so worried. I don't understand what his father told you.
Well, yes, I can totally understand your concern. His father told us that he was playing in the playground and he just fell from the swing in the school, and he suddenly saw the discoloration on the tummy, and he immediately called the ambulance and he bring the patient to emergency on time. He didn't waste any time. That was important, to take a decision immediately.
But the child's father is drunk and I want to protect my son. How can you help me, doctor?
I'm so sorry, Miss, to hear about your husband. And thank you for sharing this information with us. What I can do is we have to involve some legal standards in this case, and we have to involve the child care protection, and we have to make sure that child is in a good hand and it's safe even after the surgery as well.
Hmm. So, doctor, how long this surgery is going to last, and can I just go and see my son?
Well, I'm so sorry, Miss. I'm afraid that I cannot do that for you. I don't want to interrupt the surgeons in between the surgery. So you have to wait for a while. When the surgery will finish, we will shift the patient to the ICU or HDU according to the patient condition, and I will let you inform. Yeah.
Oh, doctor, I really wanted to see him before surgery. I don't want to go him ahead.
Well, yes, I can totally understand your concern, and I can see you are really worried about your child. But as I said, the condition was severe, so we had to take your child to the operation theater before informing you, and that's the main reason. And but you don't need to be worried about the child. As far as the surgery will finish, we will shift the patient and you can see your child done.
Okay, doctor. And doctor, what precaution I have to take him after the surgery, after his organ is removed?
Well, this is a really nice question. As the spleen is work as a defensive mechanism in our body. So we have after removal of the spleen, we have to give some immunity by some vaccination and some antibiotics just to protect the child from getting infections. So we will definitely we will prepare those vaccinations and antibiotics for your child as well.
Oh, and when can I take him back, doctor, to home?
Well, I'm so sorry. At the moment, it's very difficult to tell you, because your child's health is uppermost priority for us. When he will be able to become normal and having a good recovery, we will definitely discharge the patient. But it's very important that before discharging, we make sure that the patient is doing well. And yes, and we will also inform the GP so he can come and visit the patient on regular basis.
Okay.
Good.
Okay. Do you want to ask anything else?
No, no, doctor.
Okay. If you want, can I summarize what we have talked so far?
Yes, yes, doctor.
Okay. So, Miss, your child came with a trauma to the tummy, and after falling from swing in the school, and unfortunately, on the investigation, we had to perform a surgery, and before you arrived, we took the patient to the operation theater, but he's in a good hand, and our experienced surgeons are performing the surgery. And as far as after finishing the operation, we will shift the patient to the HDU, and he will remain in the hospital for a few days, and give some vaccinations and antibiotics, and also we will keep him for a few days till his recovery is done, and along with that we will also involve the child care protectors for his protection at home as well, and I will also suggest some recovery from the alcoholic rehabilitation center for your husband.
Dr.
well.
Mevana, you are
Let me, ma'am.
prolonging it too much. It's not a summary now.
Okay.
Summary
fine.
should be given in 30 seconds. This you should remember. Like this is like. Yes,
ma'am.
otherwise, like whatever you were telling us, everything is relevant. But once you have to summarize, make sure you do it in 30 seconds. Like say all the relevant things in the last 30 seconds. But now Bell had gone long ago. Yes, Dr. Karma, can you?
Okay.
Yes. Please give the feedback.
Yes, ma'am. Ma'am, she covered everything, almost
Yes.
all the things she covered. But yes, like you said, she can be little fast and skip
Yes.
certain points or avoid
Unnecessary.
repeat.
Yes.
Yes, ma'am. Repetition, she can
And
avoid. Ma'am.
did you feel it was a good conversation? Like, was it a conversation?
Yes, ma'am. Yes, ma'am. She maintained a good and I think she could have empathized a little less,
Little
maybe.
more.
Yes, yes, ma'am. Or
A
like
little
Dr.
more
Karma said.
appropriately. Yes, Dr. Karma will hear his feedback first. You can
Yes.
tell. Yes, good. Okay. Yes, Dr. Karma.
Thank you, ma'am. Thank you, Dr. Mamona. Nice one. I just have one or two comments.
Yes.
Of course, like when we present also, we may not be perfect, but we are here to
Give feedback
like
and learn from each other. Yes.
feedback and then
Yes.
improve and learn from each other. That's why.
Yes. Yes.
So first thing, I think she was more of like she was talking too much, and I think she was not involving the patient too much, and she was
relative. Yes.
more,
Even though
sorry,
Dr.
more
Snehal
she was
said
more,
yes, she was not. Yes, it wasn't a conversation.
yeah,
Yes.
and she was speaking too much of details, I think.
Yes.
And few medical jargons like HDU, actively bleeding.
Yes. Yes.
These
Yes.
all
Could have
patient
been
will not
avoided.
understand.
Yes.
And yeah, and this is a stressful situation, and I think like words like nice, she was using it's a nice question. So first was okay, first when she asked like what is pain, okay, but in the second time when she said what precautions that she needs to take for her son, then it's not a nice question, like it's a worried question. She's worried about her child, so she's asking that question. So I was just thinking like if that could be avoided, like
Yes.
some examiner may not like
Definitely. Yes. Even patient relative may not like it,
yeah,
and if yes, that is offended, so
yeah,
exam is
because it's a stressful, yeah. And if it's a normal conversation, then yeah, nice question. But this is not a nice question. So that's just an observation, ma'am.
yeah, good. Thank you. Yes, attention. Right. So if you have read and understood considering this surgical pathologist patient, kindly tell me what is your provisional diagnosis for this patient?
My provisional diagnosis for this patient would be left-sided breast carcinoma.
Okay. How do you intend to manage this patient?
Management of this patient will be by triple assessment. First of
Very
all, I'm
good.
going to do a thorough clinical examination of the patient, including examination of lymph nodes. And then I'm going to go for a mammography. And after that, I'll go for a tissue biopsy, either an FNA biopsy.
Right. Considering, can you help me read this image? Can you see something?
This,
So
yes,
there are
ma'am.
three images
there is,
basically in this one.
yes, ma'am. There is the D is a mammography. The C is also A, B, C, D are mammographic pictures, and above that there is a thing which shows us a lesion, a speculated mass. The arrow shows a speculated mass within
This
it.
arrow.
The
Yes. What
glandular
type
structure.
of, yes. Can you describe the lesion that you're looking at?
It looks like a microcalcification with a radio-dense appearance.
Okay.
And
what would be your next
and
step?
that is the
What would
I
be
would
your
take a
next
tissue
step?
biopsy.
Okay. Oh, yes. A fine needle.
I would do either a true and fine dilation cytology.
Yes.
Yes, ma'am.
Then after excision, what do you expect to see in the report?
After that, I'm going to in the report, I'm going to first have to see what type of cancer it is, then the
What
size
type
of
of
the
cells
tumor,
there are,
then
okay.
margin, yes,
And
margin status, the receptor status of ER, PR, HER2 new receptor,
yes,
the 60 positive lymph nodes,
and the grade,
then any lymphovascular, and yes, the grade and lymphovascular invasion.
And the tumor size as well. You'll be able to assess.
Yes, yes.
So these are the
yes.
all common things you'll find. Okay, can you please tell me what are the most common tumors of the breast or the mammary gland?
Breast carcinoma can be ductal cell carcinoma in situ, lobular carcinoma in situ, and then it can be invasive ductal cell carcinoma, invasive lobular carcinoma.
All right. If a patient gets diagnosis that it's a carcinoma of mammary gland, who would you involve in the management of that patient?
There would be an oncosurgeon, a nurse, then a radiation, a radiologist, a radiation oncologist, a hemato-oncologist, a psychologist, a social worker, of course, the patient's GP. Then I would probably involve a gynecologist too, and anesthesiologist.
And hematologist as well.
And hemato-oncologist, yes, ma'am.
All right, okay. Can you please explain this image on both left-hand side and the right-hand side? What are you looking at? What are these red arrows? What they tell you?
These are showing again masses that are localized around the nipple areolar complex, and so there it looks like a micro calcification.
Okay. Considering mammary gland carcinoma, can you please tell me what are the genes which are involved in it?
There is the BRCA1, BRCA2, and TP53 gene involved.
All right. Any other? Okay. If you like when you did the excision and you were waiting for the report, you also wanted to know about the receptors. What does HER2 receptor mean? Presence of this receptor mean?
HER receptor, which is basically human epidermal growth factor receptor.
Yes.
This is an oncogene or a biomarker, which means that is present on the cell membrane of a cell membrane, and it is responsible for turning on and off genes by permeating signals from outside the cell to inside the cell. It basically binds to the epidermal growth factor receptor and causes cellular proliferation, thus leading to the inhibition of the MAPK or the PI3AK pathway cell division. So The presence of this receptor is associated with 15 to 20% of the cases with breast carcinoma, and the presence of this would mean that there is poor prognosis and is less
Very good.
receptive
good.
to hormonal therapy.
Yes. How the management differs due to the presence of these receptors?
A management of this would be, we would add the anti-HER2 receptor, that is the trastuzumab or the Herceptin, and we would need to add this. And this is a monoclonal antibody that acts by antibody-mediated cell destruction that are overproducing this HER2 gene.
Good. What is the role of KI gene? KI67?
Proliferation index.
Yes.
I can't recall at the moment. I'm sorry.
Okay.
Can I get back to that later?
Yes. Right. If a patient, when patient has been diagnosed once, how do you, according to the new NICE guidelines, do you plan to follow up the patient post-operatively?
So according to the NICE guidelines, follow-up will be with mammography of the patient every 3 yearly, starting from the patient's starting from 53 until the patient turns 71.
No, patient has been
sorry,
diagnosed.
post-operatively.
Yes, post-operatively. That is surveillance, but you're telling me.
Post-operatively, post-operatively, we'll have to, every 6 monthly, we have to do the mammography of the patient.
How long? For how long? You're not telling me correctly.
For 5 years. I'm sorry.
No.
I don't recall
no,
this.
it's not. Okay, you'll check up and then tell me. All right, can you please tell me what are you looking at here? These arrows are pointing at what? If you can describe the image.
This is a radio-dense lesion located in the around the is centrally placed and showing sun ray kind of appearances. So it looks like a microcalcific.
Yes.
Yes, subareolar.
Yes.
And possibly Paget's disease.
Yes.
Possibly.
Could be.
Showing Paget's disease.
What type of condition is that?
It is basically it is a condition that which is like a subareolar representation or extension of the ductal carcinoma in situ or overlying ductal carcinoma in situ.
All right. Can you tell me what is the last question, Balafon? What is the most important cell if you suspect? What is the most important test if you suspect Paget's disease?
We'll have to do biopsy, ma'am.
But is there any role of culture and sensitivity?
Culture and sensitivity? No, ma'am. No, not. If there is infection, if there is, then we could go if there is discharge. But otherwise, we'll have to go for biopsy to confirm that this is a Paget's disease.
Thank you.